and then joined Microsoft about 5 years ago, and then have been running the AI for Health portfolio within the AI for Good research lab there. And so what I thought I'd do in the next, several minutes, provide like an overview so you guys know what our group really is and what it does. Talk about the promise of AI in medicine, talk about potential perils to avoid, and talk about hope in the future with regard to AI. So the lab is run by Juan Lavista. He's the chief data scientist at Dartmouth. And wow, this is automated somehow. And the chief data scientist and a corporate vice president of Microsoft. These are the folks who he oversees, including me, who runs the health portfolio. Why is this automating? It should not be automating. So let me just back this up because this is going to drive me insane.
In the meanwhile, I again almost forgot to record the meeting, but I started recording. I hope everybody is okay with it.
So Juan is the chief data scientist of Microsoft, oversees these folks, and I run the AI for Health portfolio. You already pointed out, Sonali.
Yeah, we can't see your slides.
Okay, hold on. So I'm just going to do it like, I don't know what is going on here. Now, can you see?
Still no. If you'd like to send them to me, I'm happy to share them for you.
Now?
Yes, we see them now. Thank you very much.
Yeah, so Juan oversees us, and as you already pointed out, we have this book. And what the lab does is it focuses on 3 areas: sustainability, humanitarian action, and health. And as I said, I run the health portfolio. Juan answers directly to Brad Smith, who is the president and vice chair of Microsoft. And I should say this is, we are part of Microsoft's philanthropies. We have no revenue expectations. We expect nothing. We work with not-for-profit organizations to see how AI might be helpful in research projects. And with every research project, we seek to demonstrate the kind of the art of the possible, as well as publish an academic paper and provide the code to the world through GitHub. And any IP that we develop with a partner belongs to the partner. So we have a project, we publish it, and then we kind of are done, and it's up to the partner to continue. And we've had several projects with Fred Hutch, including like there was a chat bot for smoking cessation that was pretty successful, I think. What's going on? This is bad when Microsoft's own technology doesn't work on a Microsoft call. Okay, so the areas of interest that we have in the health area are computer vision, including things like segmenting organs and cancers, edge use of AI for diagnostics, where we only do proof of concept. We do not want to be seen as a medical device company, but we can say, hey, this seems to work. Public health, where we are working on use of social determinants of health for city planning. I'll give you an example of that later. And large data set analyses, where we can use more recent tools in analysis of like maternal fetal health and sudden unexpected infant death syndrome. And then large language models, where we are working, for instance, with WHO to do data summarization efforts. They get these huge streams of news data, and so the idea would be to replace or reduce the human component of that effort, to summarize things, to identify where outbreaks might be occurring. And similarly, we're working with Kaiser to develop guidelines in a much more quick way, right? Because guidelines, you guys are providers, I think, on the call. Guidelines take some time to develop. So sometimes by the time you've developed them, some of the initial work is already out of date. So can you shorten that time period to provide more up-to-date and even update them much more regularly guidelines? So now I'll talk a little bit about the promise of AI in medicine in a few different areas, general clinical care. I think for me, I always try to remember what the goal is. And I worked in quality improvement and patient safety for quite some time while I was at Dartmouth. And so the goal is to improve value in healthcare. And value is defined as quality over cost. And we know from the quadruple aim that there's three components, now four, of the numerator, which is improving the patient experience, improving the provider experience, and then improving healthcare quality and outcomes, but in an equitable way. So that's where it became the quintuple aim. And all of this while we're trying to reduce per capita costs. So this is the goal. And when I give talks like this, I invariably say if we're introducing a new technology that does not measurably achieve one of these four quadrants of the quadruple aim, we should not do it, right? We fundamentally, we're just adding costs and adding burden to the system if we are doing that. So this is the overall goal, to improve value. And so we can improve value by thinking about what the care process is from a clinician's point of view. And this is just a nice example of how at Dartmouth we kind of conceptualize what the care process is, where you have a group of patients who have needs, they're assigned to a system, they're oriented to it, they have some kind of initial workup and plan for care. They then are engaged in acute or chronic or preventive or palliative care, and then they have some kind of a outcome at the end that could be measured against their initial status on several quadrants: the biological, functional, patient expectations, and costs. And so this is kind of how healthcare kind of happens conceptually, and ways that we can improve the healthcare process using artificial intelligence. And in particular, I think the large language models is through backroom operations for providers. You guys, I think a number of people on the call are providers, yes?
Yeah.
Yeah. So we all know the joys of having an EHR and how useful that was, right? And how it's like massively contributed to burnout, right? But I think the generative AI models, the LLMs in particular, are pretty helpful in these basic routine things that can free up physicians' time to and other providers' time to spend more time with patients. So thinking about scheduling and letter writing and summarizing record content, providing some decision support that I'll get to a little bit later, and also ambient AI. And I don't know if you guys are familiar with the nuance tool of ambient AI, where it's kind of like fascinating to me as a provider, where you have a computer essentially on the wall that can listen to and record multiple in the room. Let the provider actually examine and talk to the patient and look at them in the eye instead of looking over here and typing, and then provide a SOAP note for that encounter that is probably more accurate than we might be, particularly if we wait till later at night to record our 20 or 30 visits during the day, right? Might capture it more accurately. It might identify some particular nuances that are captured with other people in the room talking, and it can also help suggest next steps, right, with some decision support. Mrs. Smith has not had a mammography in 5 years, needs a mammography. This guy needs some vaccines because he said he was going to go on a trip to India or something like that, right? So it's fascinating. It's very supportive. It goes to the provider always for their sign off. And I think that will bring back medicine to how it was kind of before the EHR put the screen between us and patients. And so I'm very hopeful about that. And here, with regard to the quadruple aim, I think these kinds of things that I just mentioned all enhance provider experience, patient experience, outcomes, and probably will reduce care costs as well. Another application is enhancing internal and cross-system learning. Like I said, I was part of quality improvement for quite a while. And when we examine, health systems and we compare them to one another, or health providers within a system, we see that there's variation in outcomes. And here, for instance, is an example of in-hospital mortality risk adjusted. And we see that there's substantial difference across systems for this. And we could imagine within the system that the best performing provider, if this data is collected and analyzed and risk adjusted on a continuous basis, the best provider could teach the less well-performing provider about what they're doing, and they could share knowledge and share processes. But even better, right, may be that sharing of these processes across systems from the very best to those who are not performing quite as well. And here too, I think the quadruple aim is quite met. Informing diagnosis. So we know as providers that we see patients kind of irregularly every year, perhaps or so. And if we see someone who has some particular measure and we get kind of a metric like this, we might see that there's a kind of a downward trend that we see over a 6-year period, with the fifth year being kind of an outlier and throwing us off a bit. And symptoms might have been reported there. But if we were able to use, smartwatches and just additional sensors in the home or worn by people, we might identify that there's variation in this measure changes in a much, when we're talking much more granularly on a time perspective, and that we should see a change in the variation at this point. And so perhaps this kind of earlier detection might help with patient outcomes and so forth. It could be that, again, providers like to treat patients and help them, so their experience goes up. The patient probably wants to have earlier diagnosis if they're feeling strange as well. The cost might be additional because the additional technologies required. So that's kind of some clinical care. I want to just talk about another area that we're working on in the lab, where we're expanding the provider workforce, particularly in low and middle income countries, but also this applies to rural settings and to anywhere. I live in New York City, anywhere where there's difficulty accessing care because people have multiple jobs and stuff like that. So I'll talk about retinopathy of prematurity. These are, again, projects that we've done. They're covered in the book. So it's increasingly diagnosed as children survive prematurity. It's the leading cause of lifelong blindness in children, has a prevalence of about 5 to 8% in high-income countries and up to 30% in low and middle-income countries. The challenge with ROP is that premature infants need to be screened repeatedly, but it is treatable. You can give medications and laser surgery to actually treat it and prevent the ROP from, progressing on to blindness. And pediatric ophthalmology is a very scarce specialty, both in LMICs and in the US. So what we've done is we've created a application that can take, this is a community health worker who's got a child there where the pupils have been dilated, looking through a magnifying glass and just taking a picture with a phone, right? A video with phone. This video then is assessed immediately for quality check to see whether there are adequate retinal frames. If they're inadequate, it says redo it while the kid is still, anesthetized or sedated. So you don't have to come back later and do it, and you're right there. If it's adequate, you get this, you get the best frames are automatically chosen, and they are run through an algorithm that says, gives a probability that the patient has ROP. That then prediction is sent to a pediatric ophthalmologist, and as are the frames and the video as well. The reason that this kind of expands the provider workforce is, as the providers know on the call here, providers spend a lot of time screening, particularly in areas where there's not a lot of access. They do a lot of screening, and they also spend a lot of time on normal. So if you can get providers like scarce specialists like pediatric ophthalmologists actually treating patients and not spending 50 or 70% of their time screening patients, you've tripled the workforce like that, right? Just overnight. And so that's where something like this can be useful, again, in LMICs or anywhere where there's kind of a scarcity of specialties, particularly in rural settings. Leprosy is another area we've worked in. It's relatively common in certain low and middle income countries. There are about 200,000 new cases each year. People who get leprosy are stigmatized and ostracized and often kicked out of their communities. Dermatologists is another scarce medical specialty where the same kind of argument for expansion of the workforce applies. Untreated, leprosy can cause disfigurement, but is imminently treatable. And so here we did the same similar kind of a thing where you can take a picture of a lesion on the skin. You fill out a patient questionnaire about tingling and different kind of symptoms that might occur. These are the symptoms, whether it's thermal sensitivity, whether it's nodules, paresthesias, actually gender matters as well, and the location, these kind to them, and then you generate a probability that the lesion is leprosy, and you create an automatic referral if it is. Again, now this can happen in the community with community health worker. It's very simple to do, and the scarce specialists of dermatology can be used to treat this, and even do it, from a telecommunications way, because these are just medications. Now I'll talk about some public health applications that we've worked on. One is predicting childhood malnutrition in Kenya. So in sub-Saharan Africa, childhood malnutrition is a chronic problem. It causes a lot of delay and stunting. Survey data are collected in this DHIS2 report, and they report on childhood malnutrition rates, but these are lagging indicators. So it says, last month, or actually 2 or 3 months ago, by the time the data get in, these were the malnutrition rates. So if I'm a public health official or in charge of the Ministry of Health, by the time I do humanitarian action to address the malnutrition, it's kind of too late, right? The surge has already happened, and it's too late because the kids are already being affected by malnutrition. So the question that we wanted to answer is, could we use DHIS data at the sub-county level? There are about 300 sub-counties in Kenya, and satellite data as well to predict childhood malnutrition rates in the future. And so here we are, results from a number of models. You guys are probably familiar with the AUC, which is what this is reporting. We're trying to look a month ahead of time, 3 months ahead of time, and 6 months ahead of time, and see if we can predict malnutrition rates at the sub-county level. And when we add the satellite data, which is the gross primary productivity from satellite, we get pretty good results of 0.89 and 0.85 at the 6 month level, 6 months. 6 months in advance, and 0.87 at the 3 months in advance. The idea being obviously that if the crops are failing in this particular area or they're not growing as well, in several months when they're harvested, there will be less food. This might impact childhood malnutrition. So here too, then a health minister can begin to intervene much earlier than 2 months after the fact. They can anticipate when the malnutrition is going to peak. Another public health application is using social determinants of health. We all know perhaps that social determinants of health are more responsible for health status than is the health care system and the health care that people are receiving. And so we are collaborating with the Novartis Foundation, New York University, and Weill Cornell in the AI for Healthy Cities project, which uses local SDOH data to help policymakers determine what SDOH interventions might have the most impact on cardiovascular risk at the geographic level. We're working in New York at the top, but we're also working in a variety of large cities like Lausanne, Helsinki, and Singapore. And we think there might be future applications in LMICs once we figure this out. So here is an example of the observed diabetes prevalence. We can do this for hypertension or whatever, but New York actually has a new law that says that their trying to reduce complications from diabetes. So we focused on diabetes a bit. So the observed diabetes prevalence is on the left. And then on the right are two models that predict diabetes prevalence based on SDOH from non-New York census tracts applied to New York City. And what we find is there's tremendous alignment with what the actual diabetes prevalence is, whether we use a more complicated model with all variables or a narrow variable set in the middle. But essentially the numbers come up pretty much the same when you look at this. And the nice thing is, you all probably know, is when you use the SHAP values, you can actually show the the administrators and the policymakers, what the relationship is, what's contributing most to the model. And for instance, see that, single parent families is not going to do quite as much as education or SNAP benefits, which would be a very simple solution, right, to a problem like this. So those are kind of the areas that they're working in, just some examples of both clinical care applications and public health applications. I'll talk about some perils that we should try to avoid. First, as you all probably know, there's a lot of hype, right? Can AI save our oceans? Will it defeat cancer? Will it save us from ourselves? Will we all lose our jobs? And frequently when I'm giving this talk or a talk like this, I'll ask people, is AI going to save the world or kill us all? And it's kind of split. It's kind of 50-50. But there's a lot of challenges in understanding AI. There's partial truth and partial hype, and a lot of jargon lead to massive confusion. And when I give talks to people who are not as involved in AI, I will often remind them that AI is a concept that was developed in 1956 at Dartmouth, where I worked for many years. We all use AI all the time. So if you use Amazon or Netflix or a car or a phone, you're using AI. And I think most people who are less familiar with AI think of AI, that's when ChatGPT came out in November 2022, right? That's how they think of AI. It was this new thing that started then, but we've been using this kind of stuff for years. So to kind of allay some of the fears that this is going to take over, people find this kind of stuff fairly useful, I think. One of the pitfalls, so there's this massive confusion and kind of lack of understanding, I think, even of what AI really is in the general populace. I think this is another peril, that there could be a haphazard application. And this, I think, is particularly important in healthcare, where the risks are very real. This is a Bill Gates quote that, essentially, if an organization is efficient, technology will help it become more efficient. And if it's not efficient, AI will accelerate the inefficiency. And healthcare is not known for its efficiency, right? So we need to be careful about how we apply this along the lines of the quadruple aim concept. We should not just add costs if we're not achieving those other goals, right? Because AI is expensive. It's not a one shot and you're done. I'll get to that. You have to maintain it. It takes smart people to engage in it, and you have to update it kind of constantly. So be cautious in its use is kind of my rule. I think we chase the wrong metrics a lot. For the clinicians know, there's kind of clinical impact and there's statistical outcomes. Too often, I fear, when I work, and I'm not a AI technology expert, right? I'm a physician-economist who worries a lot about value. But too often we look at model fittingness as the key outcome, the AUC, right? And is the AUC better? And to me, the analogy from a clinical standpoint is kind of, statistically, the blood pressure dropped by 2 milligrams, right? Or millimeters of mercury, right? That's what it dropped by. It's clinically totally irrelevant, right? You have more than that variation when you take the next blood pressure, but it may be statistically important. So we need to be cautious about not just understanding the metrics and the statistics, but really thinking about, is it having some kind of meaningful clinical impact? Is it worth this investment? If it's a millimeter change in blood pressure, is it worth the additional costs to get that as a return on investment? And understanding part of that cost is ongoing monitoring of the systems and the AI models. This, I think, is a really big challenge, not having an expert human in the loop. And by an expert, I mean a clinically informed one. We too often, and I've seen this in our own group, to be honest with you, we have people who are data scientists and computer scientists, and they're real eager to do stuff. They don't have a clinical understanding of how stuff works, and so they will just take data and put it in a model and run all these things, and then and it would be what I would have called fishing in the past when I was younger, when you do an analysis, right, without kind of a hypothesis, without an understanding of how things work. And so so you really need a clinician in the loop to say, this makes sense or this doesn't make sense. And from the beginning, and you need to have a hypothesis and you need to think things through. We have gotten erroneous findings sometimes where people kind of haven't looked at the data and haven't kind of understood the meaning of the data. And so they find these results, and then you kind of have to backtrack and redo it because things kind of went awry. I do think that, in particular, if you're trying to convince clinicians, using interpretable AI models and tools like generalized additive models and the SHAP values that I showed you, that will help clinicians kind of believe in this, right? The clinicians among you know that we went to school for a really long time. We have a pathophysiological basis of disease that we believe in, that this is how it makes sense. And so if someone says, if you do this, this will be the outcome, but I can't tell you anything about the middle, like a miracle happens from the old cartoon. If I can't tell you, I'm not going to buy it, right? I want to have proof. I want it to make sense. And these kind of approaches help make sense. And the other thing is these models are invariably tested and developed retrospectively, right? And so just as with any QI effort, we need to pilot, we need to test for unintended consequences, and we need to make sure that the promise of the model is actually doing what the model says. I think we need to do this in a rigorous way. I've seen too many companies come up and say, "Oh yeah, we did this thing and it works great, and there's a 30% reduction in X, Y, or Z." And there was no control, right? There was no, the analysis might have been for 2 weeks or something like that, right? So it needs to be rigorous. It needs to be done in the same way that you might do a drug trial or even an important and meaningful quality improvement effort. You all know probably better than I about the biases that are inherent in some of the models, right? That because of that very last point that we use retrospective data, we use retrospective data from people who were in the original studies, who tend to be people who look a lot like me, older white males. That may not work in different populations. It sure may not work in populations that have very different healthcare systems and the way that people use those healthcare systems. So we need to be cautious about making sure that the models will apply to these different populations. And we need to develop the new models on the new populations with their involvement to understand what their needs are and what they want to get out of this, not just what we think they might want to get out of it. And I think a key finding or realization for me is that these off-the-shelf models, they have to be revalidated and include the local folks before they're kind of deployed, or you could be in for a world of hurt. And so now let's kind of move to kind of my sense of hope in the future. I think there's several truisms that AI won't replace providers, but providers can use AI or replace providers who can't. And this is kind of reality for every new technology there is. I remember I helped introduce the electronic medical record in the VA system in the kind of late 80s and early 90s. The VA was a very early adopter of EHR and had created their own EHR using their own language, which was called MUMPS. And I would, particularly among older people who've been in the system a long time, they would say, look, I didn't go to medical school to be a typist. And you're like, yeah, that's true, but this is part of the new way we work. So the typists can replace the non-typists. Similarly, people who learned to use a stethoscope when that was introduced or learned to use medications replace people who didn't. It's a new technology. It's got a lot of promise. We need to know how to use it well and carefully. Today's models will not be tomorrow. So as I suggested, you can't just take a model and implement it and then come back 10 years later and see how things are going. There will be updates. The population needs will likely change, particularly if the models are effective at kind of steering patients to the right care. So we need to think about what the next models will be and be ready to monitor and evaluate the model's effectiveness. So, primum non nocere is what we learn at medical school, first do no harm. Caveat emptor is the business. I went to business school as well, right? And that is let the buyer beware. We want to make sure we don't do that to patients, right? So some of the caution from a, business standpoint is don't just implement this stuff nilly-willy. Again, let's be careful with it. Let's not let the patient suffer. I think, in an engineering rollout, if you have some glitches, with the exception of the one, a couple of weeks ago with the thing that shut down all the airlines, but if you have a few glitches, it's not a big deal because you get the feedback and you can modify it, and so you adjust to what the consumers say. In healthcare, we don't want to do that by people dying, right? So we have to be cautious about this stuff. When you're using large language models, prompt engineering really, really matters, right? It's the Hitchhiker's Guide to the Galaxy question, right? If you get the answer of, what's the answer to life and the universe and everything, you get a number as an answer, then that's not really a helpful thing, right? You need to ask the question in a way that will be helpful to you to actually solve the problem. And I kind of advocate for this quite a bit, that evaluation should ensure that comparisons are fair. Sometimes I will see papers, particularly with large language models, that GPT or whichever one you're using is didn't operate at the same level of these three best providers in the world. So the best providers in the world got 93% and GPT got 88%. So my question is, what proportion of the world's population gets care from the best three providers in the world? And the statistical answer is 0, right? So I think if the model is performing better, substantially better than average at a 75 or 80% kind of level, that raises most boats. And that may be okay for now, particularly I think if we're worried about the vulnerable populations who simply do not have access to any care, and a 75 or 80% is a lot better than what they're currently getting. And it's better than most of them might get if they went to their local doctor. I will often bring up, much to the chagrin of the providers, right, in the room, that when we worry about these models not being 100% accurate, it's pretty clear that neither are providers, right? And since Lucian Leap wrote an article in, I think it was 1994, that found that 100,000 people die every year from medical errors, that is not abated. That has continued since that time period. So for 30 years, it's been the same number, more or less. So I think we shouldn't let perfection be the enemy of what is probably very, very good. And so this is my hope. This is I'm a big art fan. This is a guy, Gilbert Garcin, who ran a lamp factory in Marseille, France, from the time he was like 25 to 60, and then he retired at 60. And he was wondering kind of what he would do with his life, and he learned trick photography. And he brought as a manager, I think you see these management kind of ideals and very clever ideals come out in his photography. And so here, he's looking at you and looking at himself and having himself look at you. So he's kind of clever about kind of the perspectives that people have. Here, as a manager, he might be focusing on one thing when he's surrounded by a lot of other things that might need help. And here, this is my favorite picture of him, the kind of Sisyphean thing that he's, as a manager, going around and just kind of pushing out the very mistakes that he's making. The key reason to bring him up is after a whole career, he learned this new technology. He's been in art shows all over the world now. He became kind of famous, and he was able to use his kind of management expertise from a different perspective and apply it in a very clever way to this new technology in a way that was quite successful and informative and clever and artistic. And so my hope is that that's what generative AI in particular can do in the practice of medicine. So that's the talk. I'm happy to chat.
Thank you, Dr. Weeks. Questions? Sean?
Great talk, Dr. Weeks. Quick follow-up. One of the big objectives in healthcare delivery is the context of the learning organization. And I'm wondering if you could talk about AI really in how it can be used in the learning organization to improve less being part of the actual care delivery process.
Yeah, so I think like the example I use about trying to learn from best providers, first identifying them in a quick way, right? I think if you had these algorithms that could kind of monitor care as they go, and so you're not looking at care that was provided a year and a half ago with maybe different populations and maybe by someone who left, but actually almost in real time, bringing quality improvement to kind of more real-time stuff. I always tell a story. I did a lot of work with Sparks, which is a database in New York, and they have been publishing online for since 1988 physician and hospital-specific risk-adjusted mortality outcomes for CABG. And then a couple of years later, they started doing PCAs as well. And the story that I tell is that when Bill Clinton got his CABG in New York, he went to the place that was the statistical outlier of bad care, highest risk-adjusted mortality rate for the past 10 years. So this was all available on their website. It was all a couple of years late, but no one would access it. No one could use it. Patients wouldn't use it, and I'm not sure the providers would really use it. And if an ex-president of the United States didn't use information on quality, it's not getting much use. The joke was that maybe Hillary picked that out for him, but at the time, but perhaps not. Maybe he just wasn't informed. So my hope is that with ongoing monitoring, just as you can do with a watch with a patient or a phone or whatever, with ongoing monitoring of outcomes, of performance, and so forth, we can not only give feedback to providers and say, this is kind of specifically what you need to be looking at right now, and maybe here are some tools that can help you improve on this particular area. But also we can improve organizational performance and improve the care that patients receive.
Wonderful, thank you.
Thank you. Elizabeth is next.
Hi, I'm wondering, this is so wonderful to see all the very real world impact that your lab is having. If we have an idea, what is the process for your lab vetting the idea, seeing if you want to collaborate on the idea? How do we know you won't just steal the idea and run with it? Because I'm sure you could do it much better than maybe some of us can. How do we make it a true collaboration, and how do you vet potential proposals?
Sure. So we really get nothing out of this. We're purely a goodwill part of Microsoft's organization. We're purely philanthropic. So we engage with potential partners in one of two ways. One is if they already have data science expertise and they have the project, a specified project that they're working on, and they don't really need we have a bench of about 30 data scientists in our group. We're not a huge group within Microsoft. if they have that, we can grant Azure credits so that they can, use the AI tools and use the credits for free. So it's given away. We expect nothing except kind of a recognition in a paper that we provided some support. The other way, and our preferred way of working with folks, is to actually co-develop a project. In this case, they kind of reach out. If it's a health project, they reach out to me. I work with them, and we kind of co-develop a kind of a specific aims 1 or 2 pager. It says, these are the data that we're going to use. This is the plan that we want to, enact, and then that goes through our leadership team. We assign the project to one of our data scientists. We then have engagement with the partner, and we work on this stuff over time. And at the end, we publish a peer-reviewed article co-authored with the partner. The partner gets the IP, and we publish any code on on GitHub. So a couple of things about that. There's things that we only work when there's already data. So we don't do data collection. We don't create an app that collects data, stuff like that. The data need to be there. When the data are there, they are placed. We provided Azure tenancy for the partner. They store their data there, and they grant us access. So it's always on their space. They can cut us off at any time that they want. And then we work collaboratively with them to kind of do the project. The downside of that is when we engage in something like that, where we're actually touching data, we need to get what's called a research collaboration agreement in place. That's a legal document. And when you have, .edus and .orgs and their lawyers dealing with Microsoft and their lawyers, that can take sometimes as long as the project to get done. So it can be a challenging part. The nice thing about that is once we have that in place, we can slot in additional projects pretty quickly. We do, just a couple of caveats, we do kind of one project at a time with a partner, because we have a whole lot of demand, and we don't want to spend too many resources on one particular person at a time or one particular partner at a time. We don't provide checks, so we can't support faculty salaries and stuff like that. One thing we've been successful at doing, I think, is if a partner is planning to go in for an NIH grant or some other grant, I can provide kind of a letter of support saying, hey, assuming the resources are still available. It's always a cautionary thing in the corporate world, right? Assuming the resources are available, we will do this and this and that once the data are collected or whatever. And we can give you Azure credits once the grant is approved, which the funding agencies kind of like to see, so they don't have to pay for that. Like I said, we don't collect data, we don't create apps, things we don't do. I'm trying to think of. We don't work with commercial firms. If it's kind of something has a commercial orientation, a very clear commercial orientation from a commercial firm, that they can go into, there's other avenues for them to work with Microsoft. It is true that, as I said, the IP belongs to the partner after the project is done. My hope, to be honest with you, is that the partner commercializes that in some fashion, because I find it hard to believe that some of these examples that I gave of ROP or leprosy or whatever, they're not going to be adopted unless they're very easy to use, right? And so there needs to be a SKU on them. It needs to be purchasable for very, very cheap, perhaps in a low and middle income country. Nonetheless, it's got to be kind of commercialized, so it's very user friendly, and that's something that we don't do. The other thing we don't do is maintenance. So if we do the project, the code is the partners, the code is published on GitHub, the IP is the partners, but then we're kind of done. We don't kind of have an ongoing maintenance agreement.
You're on mute, Elizabeth.
You don't develop apps or software, but you do the sort of proof of principle, and then to make it user friendly, the partner would have to find a way to do that, to get it disseminated into the world.
Yeah. We can do, again, a bit of a proof of concept around that, like the ROP example or leprosy example. We just kind of wanted to see, can you use a phone? Can you do this? Here's the general way to go about it, and create kind of a mini app, but then they need to advance it to the next thing. We actually did with, I can't recall the person who we did it with, but it was a chatbot for quitting smoking with someone at Fred Hutch. And so we created this bot and kind of evaluated it.
The Bricker Lab.
Bricker Lab, yes. Yeah.
That's awesome.
Yeah.
So does that mean that you already have all the legal paperwork in place for Fred Hutch?
So we may, I would have to check on it. We may, but that I think that was done. We kind of revamped the way we did these things when I came about 2 years ago, and I think this was already in place 2 years ago. So I could check, but we revamped it so that we wouldn't have to go through this process with every single one. But at least, I mean, I guess the good news is we had something with Fred Hutch, so someone signed it over there, so we know who to contact, and so it may be much quicker.
That's awesome.
And-
Eric?
Yeah, thanks so much for joining. And so just to pile on to Elizabeth's question, do you want kind of unsolicited emails? Would you prefer they go through Brian Bott, who I think is on the call and helps out, or how can we, chat before we, what's a good feeler?
I mean, whatever works for you guys, to be honest with you. I feel these things all the time. I'm always happy to look. I can kind of make a decision, pretty quick about, does this, belong with us or some other organization within Microsoft. Key things that we worry about are impact. So for instance, we've worked some with UW and Aaron Lee in ophthalmology there, and we worked with this Lowry macular telangiectasia Institute. And so, macular telangiectasia is kind of a rare thing. We did some interesting things and found some interesting findings. We actually got a paper in JAMA Ophthalmology about that, but it doesn't have a huge impact, right? Not a lot of people have that. So working with AI for healthy cities on cardiovascular disease is likely to have a much bigger impact, and frankly, to tell kind of a more intriguing story than working on some genomics compositions of macular telangiectasia. So rare disease, we have funded like just Azure credits for some rare disease organizations, but because they're so rare, they're unlikely to have huge impact.
Got it.
More impact is better. Smoking cessation is big, right? That's a good thing.
So when you work with the data from your partner organizations, especially in healthcare, there may be PHI, right? So how does, are there specific agreements? How does that work?
Yeah,
Good
so
question.
we can work on PHI, right? And it stays again in your tenancy. We can, a limited data set is even better. So if we have age bands instead of ages, and get rid of a fair amount of the identifying data, that would be even better, right? But we can do that kind of stuff. It's always on your space, and we just kind of reach into it and apply the tools. You get IRB, we get IRB approvals for these things, which is what's kind of generally required for medicine, right? So we want to do things ethically and responsibly, and be able to put, here's the IRB number and the data was granted from the institution is granted from in the paper.
And to that point, to follow on, federation is a big emerging theme in the field, and taking the Brigham's model and trying to make it work here and stuff. Does Microsoft have a dog in that fight, or how to make that code exportable and localizable?
Yeah, we have two things that we're working on. One with this company or this organization called Vodon, which was originally designed to look at AIDS, I believe, in Africa. And so we're using a federated learning model with multiple hospitals across multiple countries in Africa to see if they, we can just essentially, and again, I'm not a technical expert here, but essentially you can reach in, look at the data, apply the algorithm, and get some kind of output on performance, right? Or whatever you're looking at. But we have someone who's kind of a privacy expert on our team, and she thinks that a better way to do it is to have some simulated data that can be then generated and run very openly, right? Because it'll reflect the performance of multiple systems, and you don't then have to worry so much about the privacy concerns. So I think there's a few ways we can kind of think about skinning the cat there, and I think for healthcare, and I imagine you think this is key, right? The only way you're going to learn to do these cross-system comparisons and see how people are performing is by looking at all the different silos that exist in healthcare. And either of those methods are ways to kind of get at that.
Awesome. Dr. Kuderer, I see your hand up and I also see your question in the chat. If you can, please unmute yourself and ask your question.
Oh, thank you so much. Yeah, sorry, I can't be on video. I'm on the go. I've actually have been very fortunate enough to advise a wonderful PhD team in Australia that has taken on AI in the health disinformation that it generates. And we've looked at all the available, publicly available generative AI models. And it's quite concerning how they're not only able to generate disinformation, health disinformation, which is going to be particularly problematic in low and middle income countries, but also the team has actually formally created a process to reach out to the companies and really does not get any responses, with this concerning information. So we don't even have an understanding, does our paper, does it have any impact with industry? And any thoughts on how we maybe want to approach this? We would love to partner with you. They're a wonderful team. If there's anything that we can, actually one of the team members would actually love to also get experience in industry to really understand the other side of things. And, might there be an interesting model? But, just initially, how can we help improve that this disinformation is starting to be tackled by generative AI?
No, I mean, you're exactly right. Microsoft has teams, large teams. One here in New York City that focuses explicitly on disinformation generation and trying to mitigate that. We actually have a paper that's under review right now on understanding health misinformation by using an anonymized Microsoft data set. And NewsGuard, I don't know if you're familiar with them, but so anyway, it's a huge problem. You're right. Essentially disinformation, I think, and misinformation killed as many people as COVID did. Because people didn't get the vaccine because they were misinformed. Right?
Yes.
So from a public health perspective, that should be integral to any kind of a public health promotional effort, is countering misinformation. So yeah, Microsoft is very, so if you want to reach out to me after the call or whatever, I'm happy to chat. We can put you in contact with the right people.
Oh, we would love that. And the team has maybe some other thoughts that might be of interest to you. So delighted. Thank you so much.
Sure.
Thank you. And I also see Brian's comment, great talk, which I would love to echo. This was wonderful. Thank you very much for your presentation. We all learned a lot. Anybody has one last minute question? Do we have half a minute left? Thank you very much. Thank you very much, everybody, for joining today. And if there are any further questions, Dr. Weeks, I'm happy to also pass them on to you.
Okay.
And thank you for sharing your time with us today. This was really a wonderful presentation. Thank you.
Thank you so much.
Thank
Nice,
you.
Thank you so
nice
much.
chatting with you. Bye-bye.
Bye-bye.